critically ill patient. I have nothing to disclose. After this presentation, we will be able to explain the role of micronutrients in critical illness, recognize the pitfalls to interpreting micronutrient levels, describe the risk for micronutrient deficiencies in critical illness, and discuss current literature surrounding micronutrient deficiency during critical illness. So what are micronutrients? They are vitamins and minerals that are vital for growth and development of the human body. Vitamins can be split into fat-soluble vitamins as well as water-soluble vitamins, while minerals can be split into trace minerals and macrominerals. Macrominerals are going to be more of your electrolytes such as magnesium and potassium. And the main difference between trace minerals and macrominerals is that the body requires very little trace minerals while they require larger amounts of macrominerals. For the sake of this presentation, we're not going to be talking about macrominerals. Micronutrients play multiple roles within the human body. These are some of them listed here, but we're going to go through them one by one. The first one is going to be cofactors in metabolism. The way cofactors work is by binding to an inactivated enzyme and thus activating it and allowing substances to bind to it, and in turn allow it to change the substance into a new product. And this is one of the roles that micronutrients truly have. Trace elements are frequently involved in this process throughout the entire body. For example, zinc is a cofactor for hundreds of different enzymes. And so if a patient is zinc deficient, you would likely see that these enzymes wouldn't work as efficiently and in turn could have impairment in metabolism for the patient. The second role is coenzymes in metabolism. So many vitamins as well as metabolites of those vitamins play an active role within complex biochemical processes within the human body as coenzymes. This is a picture of the citric acid cycle, showing multiple different sections, multiple different places where B vitamins play a role in it. You can see that they have an active role in being coenzymes throughout the entire process. And so if a patient is deficient in these micronutrients, they can end up becoming impaired in metabolism as well. Not only that, but these vitamins also play a role in the electron transport chain shown at the bottom of the screen. And you can see here that without these, there would be less energy to use throughout the entire body. The next role is going to be genetic control. And micronutrients play a role in genetic expression through the regulation of receptors that are involved with gene expression. On the screen, I have the way vitamin D does this, how it regulates retinoid X receptors. In turn, if the patient is deficient in vitamin D, then the patient would be able to express a gene that is coded by retinoid X receptors. And then for the last role is going to be antioxidants. So some micronutrients are classified as antioxidants. They have the ability to neutralize reactive oxygen species and in turn reduce oxidative stress. So on the screen I have a picture of vitamin C and how it works to neutralize reactive oxygen species. And so now I have tables showing each micronutrient as well as their roles within the human body, starting with water-soluble vitamins, fat-soluble vitamins, and then trace minerals. During critical illness, there is increased inflammation and oxidative stress. There's a complex systemic inflammatory response where the patient is releasing pro-inflammatory cytokines as well as anti-inflammatory cytokines. During this period, there's a robust and sustained effect of inflammatory response that overwhelms the anti-inflammatory response, meaning that the patient is releasing more pro-inflammatory cytokines than they can release anti-inflammatory cytokines. Also during critical illness, there is reduced plasma antioxidants as well as decreased enzyme activity of enzymes that are responsible for the detoxification of reactive oxygen species. And so this leads to oxidative stress in the critically ill patient. Some ways that this can happen is that the patient could have a compromised antioxidant capacity by having pre-existing deficiencies due to their pre-existing disease states. They can also have increased utilization of antioxidative acting enzymes, using them up faster than their body can replete them. Or the patient's just inadequately nourished in general. If a patient's micronutrient deficient, it can lead to organ dysfunction, poor wound healing, as well as an altered immune system. But if we're going to talk about micronutrient deficiency, we should also define it. So the European Society for Clinical Nutrition and Metabolism, ESPN, has a definition that they have put out there in their micronutrient guidance that they released in 2022. And so this definition is in two parts. So the first part is that the patient has to have either evidence of objective loss or intake below standard recommendation. Evidence of objective loss could mean loss due to vomiting, loss to diarrhea, loss to a high output ostomy, or even a loss through a high output fistula. The key thing to note is that patients losing more micronutrients than they can replace, or if they have intake below standard recommendation, which makes sense there. If they have one of these two, then we can go to the second part, where the patient either has to have the presence of clinical signs and symptoms of a micronutrient deficiency, or they have plasma or blood levels or concentrations below the reference range. And so we're using the definition for the European guidelines because of the fact that the American Society of Parental and Enteral Nutrition, or ASPEN, doesn't have a definition for micronutrient deficiency. They don't even have guidelines for specifically micronutrient deficiency management. But what they do have is guidelines out there that they worked with the Society of Critical Care Medicine to create, referring to nutritional management of critically ill patients. And so within their guidelines, they have one recommendation that refers to micronutrient management, and this is it. They suggest that a combination of antioxidant, vitamins, and trace minerals in doses reported to be safe in critically ill patients be provided to those patients who require specialized nutrition therapy. And so this recommendation came from the notion that the use of antioxidant, vitamins, and trace minerals could possibly improve patient outcomes, specifically mortality. So they did a meta-analysis, an internal meta-analysis, where they looked at different studies and compared standard of care to the use of these antioxidant, vitamins, and minerals. They did not publish their meta-analysis, but they did publish their results within these guidelines themselves. And so these are the results from their meta-analysis. They looked at 15 different studies and comparing the standard of care with antioxidants. And you can see here on the forest plot, you can see that there was significant difference between the two groups, as the confidence interval does not cross 1 here, meaning that based off of their meta-analysis, they prefer the use of antioxidants over standard of care to improve mortality outcomes. Now, for the first question, a 25-year-old female admitted into the ICU for hypovolemic shock secondary to a high output fistula with vitamin C levels objectively below the normal reference range. According to ESPN's definition, is this patient deficient? And you guys can put it in the chat as well. Cool. So we have here that the patient is deficient, and that is the correct answer. And so the patient is deficient per ESPN's definition because they have objective loss through their high output fistula, and then they have objective levels below the reference range, which is the second part of the definition. Now we're going to talk about assessing micronutrient deficiencies. And so we're going to be talking about pitfalls to interpreting micronutrient levels, patient-specific conditions, as well as medical interventions. So we're going to start off with pitfalls to interpreting micronutrient levels, starting off with lab draws, then lab timing, and then inflammation. Blood testing is usually the general tool that we use because it's widely available as well as inexpensive. Unfortunately, the results can sometimes be misinterpreted. There's also limited access to all the micronutrients levels in all hospitals, meaning that we have to outsource our micronutrient levels, which could result in delays, especially with getting results back, as well as issues like transporting the sample over to the facility to get analyzed, because it can get hemolyzed on the way. And then we have lab draw techniques. Proper lab draw techniques are crucial for proper interpretation of micronutrient levels. We want to make sure that nurses are flushing the line prior to the sample, grabbing the proper sample as well, whether it's plasma, serum versus whole blood, especially determining which micronutrient they're looking at. And then proper tube for collection is very important as well, because we want to make sure that the sample is stable and remains stable for analysis. So going into plasma versus whole blood is more of a long-term marker of nutritional status. It tends to not be affected by recent dietary intake and is unaffected by the acute phase response or inflammation. Plasma or serum, plasma being serum plus clotting proteins and serum being plasma without clotting proteins, are more of a marker of short-term micronutrient status. They also tend to be affected by dietary intake and are affected by acute phase response, independently of what the patient's true micronutrient status is within their tissues. I have tables here with the micronutrient, the preferred lab type for that micronutrient, as well as the reference range for adults specifically for that specific lab type. And key thing to note for this page is that thiamine as well as pantothenic acid require whole blood for their lab types. Next, we have fat-soluble vitamins as well as trace minerals. Key thing to note here is that the selenium reference range for adults is 80 to 190. This is different for our EPIC here at Emory, because for our EPIC at Emory, the reference range goes all the way down to 23, and it won't flag you unless the patient's selenium level is less than 23. And this is an issue because of the fact that if they're less than 80, they are deficient and will require repletion. So the reason that our EPIC has the reference range that goes all the way to 23 is because it includes all patient populations, including pediatric population. So if you're looking at an adult patient, please take in mind this reference range for selenium specifically. And then timing of lab draw. We want to avoid drawing immediately after or during empiric repletion of micronutrients or meals due to false elevation from contaminated samples. Not only that, but if you're getting a plasma or serum level, these meals can affect the levels significantly. And then blood transfusions may affect micronutrient level interpretation due to dilution of the micronutrient level or false elevation or normalization of micronutrient levels. So the blood transfusion itself has red blood cells within it, and those red blood cells have micronutrients in them. So when you give them, you can falsely elevate because you're giving additional micronutrients. And now we're going to talk about inflammation, which has an effect on micronutrient levels. They do this by diverting the micronutrients from or into circulation. And so if you ever think that your critically ill patient has inflammation and you're trying to get a micronutrient level or panel, you should get a CRP along with it in order to properly interpret the micronutrient levels. Alterations in plasma levels of acute phase proteins occur during inflammation through hemodilution, sequestration, increase or decrease synthesis, increase or decrease breakdown. An interpretation of these micronutrient status of the patient while they have inflammation is very difficult, and this is because there's a non-linear relationship between the inflammatory proteins like CRP and the micronutrient status. So now I have tables showing the micronutrient as well as the effects of inflammation on those micronutrient levels and the CRP cutoffs for when to expect these effects to occur. And as you can see here, some of them, like iron, vitamin B12, and A, don't have CRP cutoffs, but no, it is known that these are affected by inflammation. So off to the second question. Which of the following is not true? Whole blood measures long-term micronutrient status. Whole blood micronutrient levels are not affected by acute phase response. Dietary intake affects plasma micronutrient levels, or plasma micronutrient levels are not affected by the acute phase response. Okay, so I have D here, which is the correct answer. Okay. Now we're going to go into patient-specific conditions, going straight into risk factors first. So risk factors for micronutrient deficiencies can be diet, which makes sense. If you're taking less micronutrients in, then you're more likely to become micronutrient deficient. Alter anatomy or absorption. If you're not able to absorb the micronutrients that you are intaking, then you will more likely become micronutrient deficient, whether it's due to a surgery or like a room-wide gastric bypass or Whipple, or having a short gut due to multiple bowel resections. Another risk factor could be insensible losses, just like the Eastman definition. This can be due to disease states such as C. diff, high output fistulas, or surgical losses such as high output ostomies or blood loss. And same notion is that you're losing more micronutrients than you can deplete. So going into the GI tract, this is a picture showing multiple different sections of the GI tract, as well as which micronutrients are absorbed in those specific sections. As you can see, each single one has a different profile of micronutrients that they absorb. And so if a patient has a short gut and they've had multiple small bowel resections and no longer has an ileum, you would expect that this patient would end up becoming deficient in the micronutrients within the ileum that the ileum would have normally absorbed. Other risk factors for micronutrient deficiencies are shown here with disease states and then which micronutrients expect to be depleted or deficient in that specific disease state. But for this presentation, we're mainly going to be focusing on critical illness. But if your patient has any of these disease states prior to going into the ICU, they will most likely still be deficient in those micronutrients, and it's reasonable to check these levels. But going into critical illness, you can see that thiamine, vitamin C, vitamin D, copper, iron, selenium, and zinc are likely to be deficient in critically ill patients. But not only that, we have modalities, medical interventions that we do that can also cause even more micronutrient deficiencies, such as renal replacement therapy or medications like proton pump inhibitors or anti-epileptic drugs. This is a table showing the micronutrient as well as signs and symptoms of deficiency, specifically for water-soluble vitamins, fat-soluble vitamins, and then trace minerals. Key thing to note is that these signs and symptoms are not specific to the micronutrient deficiency, and it's very hard to tell whether or not the patient is experiencing these symptoms because of a deficiency or because of their critical illness. And now we're going into medical interventions. Starting off with medications, I've listed here multiple different medications that we see used in the ICU, specifically PPIs, H2 blockers, corticosteroids, and diuretics. Those are probably going to be the most common ones you see. But antibiotics such as cephalosporins, Bactrim, and anti-epileptic drugs can also be seen used in the ICU setting. Note that some of these only occur with long-term use, such as PPIs, and then some of them are super rare, such as cephalosporins and their vitamin K deficiency. Now we're going to go into CRRT. And so this is a modality that is essential when in order to assist us with critically ill patients with renal insufficiencies. We use it to assist us with electrolyte derangements, remove excess fluid in patients who are volume overloaded, and as well remove toxins. But with their benefits comes their non-specific removal of intravascular contents, which can lead to unintended removal of micronutrients, which was proven by the study by O et al. And this study assessed the micronutrient losses in the effluent during 3 different randomized control renal replacement therapy modalities. And what they found was that there was losses in the effluent for vitamin B's, B vitamins, zinc, iron, copper, as well as selenium. And so understanding this and understanding that patients can be on CRRT for a long period of time, and understanding that these micronutrients are being removed, it can lead to higher risk of severe clinical consequences. And so the study that was done here at Emory University Hospital, our team did a retrospective chart review where we included critically ill patients who were requiring CRRT with at least 1 or more micronutrient level obtained during CRRT. We looked at specifically the incidence of trace element deficiencies as well as water-soluble vitamin deficiencies. This was a smallish study with about 75 patients, average age of 57 years. The ICU diagnosis was not very diverse, having about 62% respiratory failure, 58% sepsis, and then 41% post-operative patients. Mean days on CRRT was 13.4 days with a mortality rate of 45.3%. And the results from the study are shown here. Key things to know from this slide is that vitamin B6, vitamin C, and copper deficiencies were very high with percentages up to 60 and up. And then thiamine or vitamin B1 was the least out of all of them. Limitation of the study was that it was a retrospective study. It had a very small sample size. Only patients who were consulted by the nutrition support team at Emory University Hospital were put into the study. And then patient sample consisted of individuals who were already at risk of having pre-existing micronutrient deficiencies, making this very low generalizability, as well as there was inconsistent lab draw routines. This was a retrospective study, so some patients had certain micronutrients looked at versus others may have not gotten the same ones. For example, some patients might have had vitamin B1s checked while others just only had vitamin A checked or vitamin zinc checked. Conclusion that they came up was that the incidence of micronutrient deficiencies in critically ill patients who required CRRT was more prevalent than previously reported. And so based off this study, Emory University Hospital started implementing an empiric supplementation protocol for their micronutrients, specifically in patients who were critically ill and required CRRT. And this is a protocol that we still use to this day. It was implemented in 2014 to prevent micronutrient deficiency specifically from CRRT. The protocol consisted of an intravenous piggyback containing B vitamins, specifically folic acid, thiamine, and pyridoxine, vitamins B1, B6, and B9. And after implementation of that protocol, the team decided to do another study looking at the effects of the protocol. So they did another retrospective chart review, including all patients who required CRRT and were on standardized supplementation protocol, meaning that they did not only limit it to patients who were consulted by nutrition support. The patients must have at least one micronutrient level obtained during the period of CRRT, and they had to have been on CRRT for more than 48 hours to ensure that CRRT had enough time to pull off micronutrients if they were going to pull off any. This study was much larger, with 259 patients. The average age was about 54 years. You can see that ICU diagnosis was more diverse here. Mean days of CRRT was 11.4 days with a mortality rate of 37.1%. And these are the results. Specifically looking at the vitamins that are in the IV piggyback, you can see the before protocol, which is the results from the previous study, and then the after protocol, which is the results from this study. By looking at the p-values, you can see there was a significant reduction in thiamine and pyridoxine deficiencies between the two groups before and after implementation of the protocol. But there was no difference in folate deficiency. Now, looking at other micronutrients that we looked at, vitamin C, copper, and zinc, which was also looked at in the first study, you can see there was no significant difference between before and after protocol. This makes sense because these were not being repleted within the protocol. Selenium, vitamin D, and carnitine were also looked at with this new study, and the results are shown there. Limitation of the study was that it was a retrospective chart review. Patient sample also consisted of individuals who were at risk of pre-existing nutritional deficiencies, and we still had inconsistent lab draws. But what we concluded was that the current empiric supplementation protocol that we used during our CRRT for our critically ill patients reduced the incidence of thiamine and pyridoxine deficiencies significantly. So this is a chart showing documented micronutrient deficiencies from CRRT from multiple sources, and these are the vitamins you would expect to be deficient when patients are on long-term CRRT or are on CRRT in general. Okay, so next question, question 3. a 45-year-old male with end-stage renal disease on CRRT in the ICU at Emory University Hospital is receiving empiric micronutrient supplementation per protocol. Which of the following micronutrients are likely to be deficient? Select all that apply. Let's see what we have in the chat. All of them. So not all of them. This patient is receiving the supplementation protocol. So we have our B vitamins within our supplementation protocol, specifically B1, B6, and B9. So patient would be deficient in, will most likely be deficient in copper and vitamin C as they're not getting repleted. Now we're going to go into ECMO. So this has seen increased utilization in the past couple of years. It's a viable supportive therapy for patients with acute severe refractory cardiorespiratory failure. It has the potential to increase patients' nutritional requirements due to altering the supply and intake of macronutrients as well as micronutrients. Right now, there's very limited data out there looking at ECMO's effect on micronutrients, but I am doing my research project on this, looking specifically at micronutrient deficiencies in ECMO patients. But once we have results, we'll start sharing those. Until then, there's just not much out there. These are the hypothesized micronutrient deficiencies from ECMO. And I say hypothesized because the literature out there is just very not good. Majority of them were just case studies or case reports, but these are some of the vitamins and minerals that are hypothesized to be deficient in ECMO. Now we're going to go into literature review in critical illness. Starting with micronutrient deficiencies in critical illness. This was a prospective cohort study of critically ill adult patients, where they compared those patients with a control group consisting of volunteers who were part of the general hospital wards, as long as they did not have a pre-existing condition that could have confounded the micronutrient status of the patient. They looked at vitamins B1, B6, vitamin C, beta-carotene, and vitamin E, as well as selenium. They included all adult patients admitted into the ICU and excluded patients with CKD, chronic liver failure, or receiving parenteral nutrition. Primary outcome that they were looking at was comparing the baseline micronutrient levels between the two groups. At baseline, there was just not much different between the two groups as we would prefer, which is good, but this was a very small study. You can see only 42 patients are included in this study, 24 in the ICU group and then 18 in the control group. Something to note from this part of the demographic table is that the majority of the patients receive enteral nutrition with 92% versus only 8% receiving no nutrition at all and no patients receiving parenteral nutrition. And these are the results. So these are the baseline micronutrient levels comparing the two control group as well as the ICU group. And as you can see here, there was statistical significant difference and decrease in the top four, so selenium, beta-carotene, vitamin C, and vitamin E when comparing ICU to a control group on a medical ward. Vitamin B1 and B6 had no significant difference here. Limitations of the study was that it was small, it was single-centered as well. They did not assess all other micronutrient deficiencies such as vitamin D. Study was performed without additional micronutrient supplements, and at baseline, critically ill patients. So they included that at baseline, critically ill patients showed lower plasma vitamin C, selenium, beta-carotene, as well as vitamin E when compared to healthy control group. And that tube feeding was not enough to replenish these levels or normalize these levels. Now we're going to talk about septic shock, because in critically ill patients, one of the disease states that come to mind is septic shock. I won't be going through every single disease state that has micronutrient deficiency, but I think since we're talking about critical care, we should talk about septic shock. So during septic shock, the patient is in a hypermetabolic state where they have increased energy expenditure, they have inefficiencies as in anaerobic metabolism, mitochondria and cellular dysfunction, increased cellular turnover, as well as free radical damage. The micronutrients that we see that are deficient normally in these patients are thiamine, vitamin C, vitamin D, as well as selenium.
And so it's proposed that micronutrient therapy has the potential to aid with the inflammatory response, as well as diminish free radical damage and or improve metabolic arrangements. For the first study, this is going to be the VISTA study. It was a multi-center randomized double-blind placebo-controlled trial where they used an intervention of vitamin C at 1.5 grams, hydrocortisone at 50 milligrams, and thiamine at 100 milligrams every 6 hours compared to placebo to see if it had an effect on ventilator and vasopressor-free days. They included critically ill patients with acute respiratory and cardiovascular dysfunction caused by a suspected infection. The exclusion, the one that's prevalent here, is the chronic hypoxia or chronic cardiovascular failure requiring home support, meaning that patients who required home oxygen, LVADs, or home milrinone were not included in this patient population. The outcomes that they looked at was number of consecutive ventilator and vasopressor-free days in the first 30 days following randomization, and then for the secondary outcome, they were looking at 30-day mortality. This was a pretty large study with 501 patients, with the main infection sources being lung, intra-abdominal, or blood. 41% of the patients required both ventilator and vasopressor support, 21% only needed ventilator support, and then 38% only needed vasopressor support. And these are the results from the study. And as you can see here, there was only a 1-day difference on median ventilator and vasopressor-free days, with no statistical significance between the two groups. And now looking at the secondary outcome, 30-day mortality, same thing here. You can see there was no significant difference denoted by confidence interval crossing 1, as well as a p-value of 0.725. So limitations of the study is that they stopped early due to lack of funding, which could meant that this study was underpowered. Fixed dose of vitamin C was tested, and they weren't changing it based off of patient requirements. Providers were allowed to administer corticosteroids at their discretion, meaning that even the placebo group was receiving steroids if the providers deemed it necessary. Only patients with sepsis-induced cardiovascular or respiratory failure were enrolled, making this hard to generalize. Conclusion that they came up with was that treatment with vitamin C, thiamine, and hydrocortisone in critically ill patients with sepsis did not significantly improve vasopressor as well as ventilator-free days compared to placebo. The next study is a retrospective cohort study where they looked at the benefits of vitamin D on sepsis prophylaxis in our critically ill patients. They included adult patients who had suspected infections and were in the ICU. They excluded anyone who was in the ICU for less than 24 hours. Patients who were receiving vitamin D only after the diagnosis of sepsis were also excluded due to the fact that they were looking for prophylaxis. Medication history of vitamin D used 2 or more days prior to suspected infection because they didn't want it to confound the results, and then incomplete medication records of vitamin D because they could not confirm whether or not the patient did or did not get vitamin D before ICU admission. So the outcomes that they looked at was primary outcome of occurrence of sepsis in ICU, and the secondary outcomes are listed there for you to look at. This is a larger study with about 1,426 patients split evenly between the two groups. There were 713 patients in the vitamin D group and then 713 patients in the other group. For the vitamin D group specifically, vitamin D administration was about 6 days with a max dose of 1,000 units daily. This group tend to be older and more likely to be female, as well as have higher presence of congestive heart failure, diabetes, as well as CKD. These are the results from the study. I've highlighted the 2 that had statistical significance, specifically sepsis risk in ICU and the incidence of new mechanical ventilation during ICU. You can see that they both favored vitamin D over no vitamin D. Limitations of the study is that vitamin D administration was judged by the record of prescription, meaning that if it was ordered, it was considered given. They did not use the MAR or MAR in order to check to make sure that the vitamin D was truly given. Vitamin D dose was flexible in several patients. Maximum daily dose was 1,000, but some patients received lower. Vitamin D levels were unavailable, right? So if we had vitamin D levels and one group was more and they weren't equal at baseline, then this could have skewed the data, the results.
And for the conclusion, they believe that the results from the study, vitamin D supplementation may have positive prophylactic effect on sepsis in critically ill patients that have a suspected infection. And now we're going to talk about COVID-19. With the recent surge of COVID-19, I thought it would be relevant to talk about right now, especially since the early parts of COVID-19, there was prophylactic dosing of multiple micronutrients such as vitamin C, selenium, and zinc. And this is based off the notion that there was higher risk of severe disease progression with patients who had micronutrient deficiencies. But this was only supported by studies that were small cohort or case studies. Truly, there was just limited quality literature out there confirming the link between the two, micronutrient deficiencies and COVID-19. The first study we're going to look at is, the only study we're going to look at for COVID-19 is this meta-analysis that they did a few years after experiencing COVID-19, where they looked at the significance of vitamin D, vitamin C, and zinc in COVID-19 patients. They included all published randomized controlled trials and observational studies, whether they were prospective or retrospective, and they compared individual micronutrients versus standard of care, specifically vitamins C, D, and zinc. The outcomes that they looked at was mortality between the micronutrient supplementation and standard of care. Secondary outcomes they looked at was intubation rate as well as hospital length of stay. They had 5,106 studies that had to screen through for full text articles, which left them with 134 studies to assess inclusion for. And that left them with only 26 studies that met inclusion criteria and were included in the meta-analysis, looking specifically at vitamin C, D, and zinc. Micronutrient supplementation within the studies were inconsistent between them. Starting with the results for vitamin C and mortality, you can see here there's about 9 studies that they looked at vitamin C specifically and mortality. You can see that there's no significant difference as a confidence interval crosses 1 here, suggesting that vitamin C was the same as standard of care for the mortality outcome. Same thing with the intubation rate. This time with only 4 studies, the confidence interval crosses 1 here, suggesting no significant difference. And once again, same thing for hospital length of stay, where for vitamin C in general, for all 3 outcomes, there was no significant difference in all 3 outcomes. Now going to the next vitamin D. Right here, you can see there's a lot more studies here, but once again, it crosses 1. The confidence interval crosses 1, suggesting there was no significant difference. But something more interesting is this one, where they had about 6 studies, and with the 6 studies in the meta-analysis, they saw that there was favor towards the vitamin D in terms of intubation rate, as the confidence interval does not cross 1 here. Same thing with the hospital length of stay. The confidence interval does not cross the line, suggesting that vitamin D improves hospital length of stay compared to standard of care. And then finally, looking at the last micronutrient that they looked at, zinc, and mortality. This one barely crosses 1 with a confidence interval, but because it crosses, once again, no significant difference here. And so what were the limitations for the study? Most of the studies involved in this meta-analysis were just small sample size studies. They included observational studies. There was heterogeneity in the measurements of vitamin C and D, as well as the dosing. They could not assess impact of supplements on subclinical outcomes, and they did not assess all micronutrient deficiencies during COVID-19. Conclusion that came up with was that micronutrient supplementation with these micronutrients, vitamin C, vitamin D, and zinc, did not reduce mortality, and that they needed further studies to understand the role of micronutrient supplementation in these patients. So now for the next question, question 4. Empiric supplementation with vitamin D, vitamin C, and zinc improves mortality and should be given to all critically ill patients with COVID-19. True or false? Answer here is false. That is correct. Okay, so now we're going to go into the micronutrient management. So when we're managing micronutrient deficiencies, we have goals. Our goals are to correct the micronutrient deficiency, potentially decrease oxidative stress, and potentially improve the immune defense of our critically ill patients. Unfortunately, there's just limited data out there regarding appropriate dosing of our micronutrients. So what we recommend is that when you're treating these patients, we recommend that you consult your nutrition support team. But if you don't have one, eSpin also has guidelines out there. They have a micronutrient guideline in 2022, which is the most extensive, provides the most extensive guidance for micronutrient supplementation and management out there right now. Unfortunately, there are some limitations with using eSpin, specifically in critical illness. eSpin does not provide dosage recommendations for all micronutrients. They don't address repletion duration, and it's just unclear on when to recheck levels as well. And as pharmacists, we have to talk about IV versus PO, but in this case, IV versus enteral. Some of the micronutrients are only available in enteral formulations, and then some are only available in intravenous formulations. And so as pharmacists, we have to consider multiple things when ordering, as well as when recommending these micronutrients. First, patient's enteral access versus intravenous access. Just like any other medication that we ever verified, we have to make sure we know which access they have. As well as their micronutrient requirements. The more they require, the more deficient they are, the more they require. Meaning that we might need to give a higher dose, or we might need to use a different formulation with a higher bioavailability. And then bowel anatomy, which is very important. As we mentioned before, it doesn't matter if you give them entirely, or it doesn't matter if you give the micronutrient entirely if the patient's unable to absorb it. If they don't have that portion of the GI tract that absorbs it, then the patient will remain deficient, and we're going to need to use something else in order to replete the patient's deficiency. And so I have charts here with micronutrients as well as their available formulations on the market. For water-soluble vitamins, fat-soluble vitamins, as well as trace minerals. And as pharmacists, we deal with shortages all the time. And so Aspen has a pretty good website and a page on that website where they update regularly on parental nutrition product shortages. This is kept up to date, and if you scroll a little lower on the page, you can get to the section where they have considerations and recommendations. And if you click into the link where the micronutrient shortage is at, it will tell you what they recommend to do. Unfortunately, this is specifically for parental nutrition products only, meaning that you will not find information on shortages regarding to your PO only micronutrients, such as vitamin A or E. I've also added the website at the bottom for you to reference whenever you need it. And so, key things to take from this presentation is that the majority of critically ill patients are likely to be deficient in one or more micronutrient. This can be due to their critical illness, or this can be due to pre-existing conditions that they have. Interpreting micronutrient levels is not straightforward. You have to take into account how it was drawn, when it was drawn, what was drawn, as well as inflammation. And then disease states and medical interventions during critical illness may affect micronutrient status, specifically, CRRT pulling off the micronutrients, possibly ECMO as well, disease states such as C. diff, right, and just the critical illness in general. And then management of micronutrient deficiencies is not well standardized. And that's and so we recommend that you consult your nutrition support team whenever you have questions on these complex patients, or refer to the eSpin guidelines, micronutrient guidelines of 2022, though they are limited in their recommendations. And that is all I have for today. And I will open the floor for questions. And you guys can just type it in the chat if you have questions. Today, micronutrient supplementation. So Alex puts a question in. He says, to date, micronutrient supplementation in the critically ill has shown little to no impact in improving survival. Which outcome related to micronutrient supplementation in critically ill is yet to receive proper attention regarding potentially guiding future research? Which outcome related to micronutrient supplementation? I believe for your question, I think maybe ICU length of stay hasn't been really looked at that much in terms of micronutrient supplementation in critically ill patients. I think if we looked more at improving patients' outcomes through ICU length of stay, I think that's a better way of looking at it, because of the fact that most ICU patients are already critically ill. They're most likely already to the point where they might not survive, but I'm not too sure on what exactly you want to answer that question. Ruchi says, according to the first EUH study, vitamin B1 deficiency was less prevalent, so why was vitamin B1 included in the supplementation protocol for CRRT? So for the first, if we remember from the first EUH study, only 9% of the patients had vitamin B1 deficiency, right? So the thing was, every patient that was within the study were patients who were consulted by the nutrition support team, meaning that they were on parenteral nutrition. And because they were on parenteral nutrition, they all received prophylaxis dosing of vitamin B1 to prevent refeeding syndrome. And so they were already repleting. They were already getting repleted, which could have confounded the results for vitamin B1. Not only that, but the study by O et al. Says that B vitamins are shown in the effluent, so we knew that it was being removed in CRRT. And so with that, plus the fact that we were already supplementing and there were still deficiencies, we expect deficiencies to actually be higher than what was reported in our first study. And so that's why vitamin B1 was added into the supplementation protocol. Okay. So Alex is going off his question again, and he says, what about functional status after ICU discharge? That is that's a good thing to look at, especially because after ICU discharge, sometimes patients don't have improvement in quality of life. I think quality of life is probably one of the most underlooked at outcomes in all of nutrition, especially because of the fact that most people just look at mortality or length of stays. I think quality of life is probably one of the most important things to look at when you're looking at nutritional studies. Any other questions? And if that is it, my presentation, oh, I have something. Oh, thanks, Kenny. Okay, if that is it, that's all I have for today. So thank you for attending.